So Dr. Karanjia is a neuro-ophthalmologist at the University of Ottawa Eye Institute. He completed his medical training and PhD in Canada and completed a fellowship in neuro-ophthalmology at UCLA. He is actively involved in clinical trials and is a board member of the International Foundation of Optic Nerve Diseases and, of course, LHON Canada. Dr. Karanjia obtained both his doctorate in philosophy and medicine from Queen's University and completed his residency in ophthalmology at the University of Ottawa. He is currently an assistant professor and vice chair of the University of Ottawa and holds the Junior Clinical Research Chair Fellowship for Ophthalmology. Welcome, Dr. Karanjia. Claire A. Sheldon is a neuro-ophthalmologist practicing in Vancouver, British Columbia. She graduated with a combined MD PhD degree in 2011, followed by a fellowship in neuro-ophthalmology in 2013 at the University of Pennsylvania. Throughout her training, she has maintained a research interest in mitochondrial physiology and clinical interest in patients with mitochondrial conditions. Welcome, Dr. Sheldon. So this question is for all three doctors, and we just wanted sort of a quick, brief overview of how you guys became interested in LHON.
First of all, the introductions brought to mind the fact that all three neuro-ophthalmologists up here have MD PhDs. There's 6 doctorates at the center of the table. Less than 1% of MDs have a PhD, so it does suggest to me that MD PhDs get involved in weird, crazy, but fascinating diseases, like labors. So that's partly the answer to your question. Personally, I knew that I was interested in how the brain worked long before I became an ophthalmologist. So my PhD was in neuroscience, and when I became an ophthalmologist and everybody else was excited about how to do cataract surgery, I sort of had to bide my time. But I knew I was going to go into things that had to do with the brain. From there, I naturally evolved to an interest in the optic nerve, which is that cable that brings everything to the brain. And then when I heard about this disease in the early part of my residency, I came up with some questions. Why should some people go blind and not others? Why should it happen all of a sudden? Why should it be just the optic nerve? And why should it happen so fast? That just utterly fascinated me and kept me up at night. And it's taken 30 or 40 years to answer those 4 questions, but nothing brings me more satisfaction.
So I would have to say the reason that I became involved in labors is sitting right next to me. I had the pleasure of spending a little bit of time when I was a resident, actually, with Dr. Sadun, and I left that experience after 2 weeks thinking, what an amazing person and what an amazing place and things that he does. This is what I want to do. And so I'm so thankful for all of the opportunities he's provided me, and the continued collaboration that we have is phenomenal.
Thank you.
Well, I became interested in mitochondria, not only to be up here with these 2 wonderful gentlemen, but also during my PhD, I did a lot of very detailed cellular imaging, so in neuroscience, and I worked alongside a colleague who's now at Simon Fraser University, who images mitochondria, single-cell live mitochondria. And then as I was going through my ophthalmology training, I couldn't leave behind kind of the science of mitochondria, and he and I are good friends, and we were sort of bantering around some ideas, and I knew about patients who have Leber hereditary optic neuropathy, and so it was a good marriage of trying to understand the science and seeing patients that could be helped by understanding the condition. So it was a wonderful process, and I'm happy to be here today. What a good group.
This question is for Dr. Karanjia. What percentage of affected people are males versus females?
So Dr. Sadun alluded to this a little bit in his talk, and he showed you the number 4-to-1, so 4 males for 1 female. But I think this is partly highlights the importance of organizations like this. Lissa, who I'm sure is somewhere in the room, has done a phenomenal job of organizing and improving our understanding on this topic. She saw that when she was seeing people who were coming to her and saying, but they said this was a disease of men, it's not a disease of women, but I'm a woman, and she started asking him questions about that. So she started collecting information, she started collecting data. She ended up getting not 100 patients, not 200 patients, but 1,400 patients to give information about when they were affected, how they were affected. And she used that information now to improve our literature and our understanding. And that's where organizations like this can do things that we could never dream of being able to do, and are so powerful at being able to do those things. So the numbers range in the literature. I believe Lissa's data because by far it's the largest of any study that's ever been done, and that quotes a number of 3-to-1. So if you look and you look carefully, the numbers will change. But right now, I think that's where we stand.
And this question is for Dr. Sheldon and Dr. Karanjia. A little bit of a longer question. A family member of a distant LHON relative comes home from school one day suddenly complaining of blurry vision at age 15. What are the next steps that a family should take in Canada? Could you discuss the need for urgent referral to a neuro-ophthalmologist and how that works in Canada through a GP? And how do you communicate with the neuro-ophthalmologist office that it may be LHON and the urgency of being able to get in, and how that first appointment should go?
Okay, that's a very, that's a big question.
Yeah.
But if I take a bit of a step back and sort of say, well, how are patients who have, if you have blurry vision, sudden onset of vision loss, how do you get to see an eye doctor? In British Columbia, you can get to see an ophthalmologist through a referral via your family physician. You can get to see an ophthalmologist through a referral by an optometrist, which are generally, you can walk into an optometry office to be seen, then get a referral to an ophthalmologist if felt to be appropriate. And optometrists can refer to neuro-ophthalmologists directly. In addition, I would stress that particularly in the Canadian system, at least in British Columbia, if somebody is having vision loss of any sort of etiology, you should present to the emergency room, which speeds up the whole process tremendously. And so in particular, in big centers, if you go to the larger hospitals, they can get directly a neuro-ophthalmologist directly on the phone. And that's pretty the fastest way to get through things. If there is so that's sort of vision loss in general. If there's a suspicion, even before they get to see an ophthalmologist or a neuro-ophthalmologist, that it is Leber hereditary optic neuropathy, if that is written on the consult note, I see that patient very quickly. And in addition, if the patient knows who they're going to see, a helpful phone call to the office to say this is the situation often really speeds up the process. I have found in the Canadian system, while it might be a bit slower than the American system, if patients are advocates for themselves, it also can be a bit faster in that way. And personally, I like working with patients who, if haven't had that blood test or didn't get to see that doctor or get the MRI scan in the timely fashion that I said we should. Sometimes that information doesn't get back to me. If that patient feeds that back to me, we work together to make things happen quickly. During the first assessment, you get to sit with me for about at least an hour. It's a long assessment. We sit and we talk and we go over the history, past medical history, past ocular history. I do a full neuro-ophthalmologic examination, which includes, measurement of your vision, measurement of your visual fields with testing, OCT pictures, and then you get the complete the examination with myself. And then we summarize and put everything together depending on what I feel is the ultimate etiology. If I am suspicious that it is Leber hereditary optic neuropathy, and this is an acute presentation, in my end of the country, I have a few options open to me in terms of expediting testing if I feel that that's indicated. I work closely with medical geneticists, and they have streamlined the process that we need to go through to get the genetic testing, because unfortunately in British Columbia it is a process that can take 3, 4, 5 months to get through. So I work closely with medical geneticists where we can expedite that, get approval through the provincial government, and get the testing done. So there are ways to get things done quickly. And I'm happy to work with the patient to make sure that that happens. And Rustum, let's hear what you do.
So I'd like to echo exactly what Claire said. We try and get people in as quickly as we can, but we can only do that on the basis of the information that's given to us. And certainly I know it's difficult to get in to see a family doctor in some cases. Some people don't have family doctors. Optometrists are accessible, and that's usually a good doorway to get into the system. And as Claire mentioned, our emergency departments are there for a reason. If you have vision loss, sudden vision loss, going to the emergency department is by far the best thing you can do. It may take the rest of your day, but it is more important to see somebody if you're concerned than letting it sit. Now, I get referrals from optometrists, I get referrals from other GPs and from other ophthalmologists, and as I'm sure Claire knows, we get hundreds of these in a week. And so it is a challenge sometimes. And making that telephone call, you may not hear back from us right away, but we do try and get things to move, and we try to work within the system in order to get things to happen. I have a little bit of a luxury here compared to Claire in that the Ontario government decided to set up a genetics testing laboratory. And so I just need to fill out a requisition and send you down to get some blood work in order to get the genetic test. Unfortunately, that still means it takes about 4 to 6 weeks to get the results back. So there can be a little bit of a delay in that confirmatory test. But if you have a family history of labors and talking to your family and understanding that and knowing that can also help expedite the system. Because if you know that, then when you go into that optometrist or you go into the emergency department, you can tell them, I have a family history of labors. And they may look at you dumbfounded and not know what that is. But that doesn't matter, because they'll put that on the requisition. And it will get to somebody who knows what that is. And they'll know what to do with it. So speaking to your relatives is a very important thing.
Call it Leber's hereditary optic neuropathy.
Yeah.
Yes.
Yeah, and you could even be a bit more general and just say there's a family history of an optic nerve disease. And I think that those emergency physicians are going to think, oh, optic nerve. They might go down the road of optic neuritis. They might, but frankly, if they go down that road, you're going to get to us the same way, and we're going to know what you're talking about when you say Leber hereditary optic neuropathy.
I just wanted to make sure they don't call it just Leber's, because then it'll be Leber's hereditary. There's a retinal disease called Leber's too. Thank you.
So I guess the follow-up question to that would be, what are the options post-diagnosis in Canada at the moment? Or what would you recommend sort of post-diagnosis for a patient who's just being diagnosed with LHON?
So I take this question in 2 different ways. So I have some patients that have come to see me who have been diagnosed decades before, years before. And I trained with Alfredo, so my thought process is very much aligned with his, and I take pieces from other people as we go along. But I find that if a patient's never taken Idibinone, which is probably the only thing we have accessible right now, I talk to them about it and give them the option to consider it. I feel, as Alfredo does, that it's worth playing all the cards that you have. Outside of that, if it's a patient who just converted and they have, depending on the mutation, I start to talk to them a little bit about clinical trials and what options are out there. Unfortunately, there aren't really any clinical trials taking place in Canada right now, with one exception, which I think we'll get into a little bit later on for LHON+. The trials in the US, a large number of them do pay for transportation, so that helps cover some of the expenses. Some of them don't, however, so the transportation costs are covered by you. In addition to that, some of them require monthly visits. Some of them may require you to be down there for a week or 2 weeks at a time in order to be able to do all of the testing. So I try to go over a lot of that detail and some of that information, because I think part of it, my job, is to empower you and to give you that information so that you know what your options are and what you can do.
I would echo the exact same comments with maybe one addition for both of those. We've just stressed lifestyle modification in terms of smoking and alcohol and toxin exposures. But again, I do discuss clinical trials. Patients who have a new diagnosis of Leber hereditary optic neuropathy, whether new or old, are going to have, or we're going to be looking into that condition and need to have the information about them. And so, yeah, it's a long conversation to have. And we have tried a couple of times to send patients for clinical trials in the United States, and the centers are really accessible. There are contacts that we have, so we can contact them and say, look, is this particular patient with this particular scenario eligible? And they can either give us a quick yes or no, and then decide what the process is from there. So it is not a barren wasteland up in Canada. We do have access to some clinical trials up here. And then certainly the idabenone and lifestyle modification we talk about all the time.
I have Canadians in at least 3 of our 5 clinical trials.
So I have a question sort of related to what sort of information should families be collecting in order to best sort of prepare themselves down the road.
Sure. So I think the information about Leber hereditary optic neuropathy, just make sure it's the right Leber condition. So if it truly is Leber hereditary optic neuropathy, what would be useful to know is the variation that is within that diagnosis, and maybe a bit about the clinical history of the patients who are affected and how the diagnosis was made. I see a number of patients who have had an incidental diagnosis of an LHON, being a carrier for LHON. That's an important piece of history to know that in the family there's nobody that's affected. This was an incidental finding, but it's still important to know whether how it was identified and the type of variation that was found.
I might add that in addition to an extensive history of this sort, you want an honest history. And I would say 90% of my patients are, but once in a while somebody won't tell us about an exposure to alcohol especially. It's really useful. And you know, this is no time to be shy, and so it'd be much better to be up. And there'll be circumstances, especially usually the guys who've gone off to college, where I might suggest that the parents leave the room. But we need to have exact numbers, not, oh, I have a few drinks.
Can I just say that I think that's even important in the middle-aged population where we see a lot of women becoming affected. I think that clear history about toxin exposure, diet, alcohol is really important, and that's a hard conversation to have with patients, but it's really important to understand the risk of the disease.
This question is for Dr. Sadun. What is LHON+?
What is LHON+?
Mm-hmm.
It's more than the optic nerve. And again, to be clear, that's the exception to the rule, but once in a while, even though the optic nerve is sometimes what I call the canary in the coal mine, it's the most vulnerable of the tissues in your body to this mutation, the LHON+ is a reminder that the entire nervous system is somewhat vulnerable. And so it almost always involves other parts of the nervous system. It might be the fibers that are longest. It goes to your hands and feet, and you get the peripheral neuropathy. It might be the long fibers that go to the heart that allow for the conduction of the heart to be involved. I don't think it changes anything too fundamentally. And I think it's important to reassure people that it's not like it's a march that's going to go and involve your whole body in lots of different ways. Think of it, which is true scientifically, that LH1 is one of the mildest mutations of the mitochondria you can have, but sometimes it involves a little bit more than the optic nerve.
Are there specific trials for LH1 plus patients?
So there is one trial that's currently enrolling patients. It's run by Stealth Biotechnologies. Unfortunately, they weren't able to have a speaker here today, but there is that one possibility, and there are 2 sites in Canada. There's one in Hamilton, and then there's one in Vancouver that is still currently recruiting.
Okay.
So you touched on research in Canada earlier, so I just wanted to circle back to that. What is currently being done in Canada, and what can this group do to push further clinical trials in Canada?
You're not making it easy on us.
These are really big questions.
Can I lay out maybe a broader question before we get to that narrower question?
Yeah.
And that would be, why is it, what problems, what challenges exist to research in labors in general? And then perhaps that'll help fuel what you can do. Number one, the disease affects about 150,000 people. That makes it a very rare disease. That means that you're going to have to show your organization as a way, just like LISA has done for us, of bringing people together. Because if a center decides that it wants to look at all the patients who live in that city, that's not enough patients to do anything with. So it's just an issue of numbers. 2 is that the disease has at least 3 and probably more mutations. And we've learned the hard way that when we mix these mutations, because they do run slightly different courses, it really makes the statistics more complicated and not work out well. So now we have to further subdivide by the mutation types to do good research. 3, the disease works at different stages. You've got this preclinical phase, then things start to get worse precipitously, then they continue to get worse a little bit slowly, and then if they're going to improve, they don't do so for 2 years. Now, if you've got 20 patients of one mutation, that sounds really good. You might be able to do something until you realize they're all going to be taken into the clinical trial at different stages of the disease. And so some are getting better while others are getting worse. There's a natural history that really confounds things and makes it very, very hard. 4, an issue that was alluded to earlier here. Once the cells are dead, they're dead. Optic atrophy is not reversible. So we might be working with that tiny little bundle of fibers that are in the dormant state and coming back, but it's not clear how many are in that. And 5, politically, it's an orphan. There's not a whole lot of people in your parliament, our Congress, who are ever heard of and therefore behind the idea of doing research in that area. So to many of these issues, an organization like this can do a great deal. It can help create a registry so you can find the right patients. It can help accelerate the timing to diagnosis, so at least the patients are coming in early enough that they can be checked in for the right stage. You can create some political awareness so that you get enhanced research. All these things that I'm bringing up, I think, are going to be universal, American or Canadian.
Absolutely. And just to add to that, I know that a lot of the trials, and some of you may look on, there's a website in the US called clinicaltrials.gov, and one of the requirements for a lot of the research ethics boards to provide approval for a clinical trial to be run at a university center require that clinical trial to be registered on that site. So that site is very complete and has a lot of information on it. And if you go on there, in some cases you'll see it's just for patients with 11778. Now, that, in a way, is a bit of an artifact of the system because they're trying to recruit a homogeneous population. They want to get people who have the same mutation. And just by sheer numbers, that happens to be 11778. It also has a more established clinical history. We understand what happens more because there are more patients. That's not to say that the other diseases may not benefit from the same therapeutic intervention, but they want to try and validate what they're doing to prove it doesn't harm people, which by far is the most important thing. But they also want to be able to show a benefit. And it's a lot easier to show a benefit if you have the same starting point across all of your patients.
One more thing that this organization can do that would be of great assistance is, you probably are not aware of this, but every research group working with their universities has to answer to a board. This is a good thing, the Internal Review Board, that wants to make sure that research is not done in a way that exploits or harms patients. It's a great idea. But one of the rules of the IRBs is that the doctor can't pick up the phone and call up his patient and say, hey, come and join this trial. If we go out to you, we might be coercing you. We might do it in a way that is not neutral. However, you're allowed to talk to us. And the organization, therefore, is a wonderful way of fairly getting around this issue by saying to everybody on the website, there's this trial. If you're interested, contact the doctor. But don't think that we're not interested in you when we don't contact you. We're not allowed to.
I just want to discuss one point, which was something that Dr. Sadun mentioned. I think it was point number 1, is how do we understand the burden of this condition within Canada itself and try to understand this condition within the constraints of our system. And I don't think we have good numbers to look at, how frequent or how prevalent is this condition in Canada. We do know that the 14484 seems to be more common in Quebec. I think the 11778 is more common in British Columbia, and we did a short study looking at our 20-year data on how prevalent the condition is in British Columbia, and it does sit right around the exact number that we expect, 1 in 40,000, something like that, in British Columbia. But we do need, with those numbers of how common it is, then we can go up to, my plan is to go to the provincial government so that I can get expedited testing when I think it's indicated, because that delay to diagnosis to me is really unacceptable. And given these extra hoops that I have to go through to get the diagnosis, having a group like LHON Canada behind me with my numbers of my database, it just is incredibly helpful. So I'm really pleased to have such a group, and I think, Lisa, you and I already talked a little bit about some of this delay, and you are in British Columbia, so this is a really good connection we've already made.
So I'd just like to add to that, one of the big differences between Canada and the US is that in the US, the FDA has a system for orphan diseases, whereby they expedite and allow a little bit more laxity when it comes to clinical trials dealing with rare diseases. And it's not to sacrifice safety. They don't want to do that. But what they understand is that it's going to be difficult to recruit 1,000 patients for a clinical trial. It's going to be difficult to do things that you would normally do if you were trying to figure out whether a medication for high blood pressure works. So that allows companies to have a little bit of an easier access system to be able to do things in the US. And that's one of the reasons that we see more trials in the US than we see in Canada. And part of the advocacy of this group is also approaching that and facing Health Canada as well to support the companies and to support their initiatives to try and get clinical trials into Canada. And that goes two ways. It involves us helping us show the companies that they're patients that are interested and motivated to participate in these studies, and that there are patients who are motivated and helpful in getting Health Canada and their MPs behind doing these studies in Canada.
I just did a little bit of arithmetic, by the way. There should be somewhere in the range of 700 people in Canada who are carriers. That's an incredibly small number. Yeah. That means that if 1 out of every 100 people any given year went blind, which I'm not, but just to put it in perspective, would mean only 7 people converting per year. So the numbers are really very, very small.
We're actually going to open up to Q&A. So, but
you guys keep talking about 1178. I'm on 3640 and 3697. Is there trial drugs out?
can we get you a mic, Trevor? Can we get a mic for Q&A, please?
You're the first one.
You're up first.
You guys keep talking about trial drugs for the 1178. I'm 3640 and 3697. Is there trial drugs out there for those?
I think that there's two questions in one. Are there drugs out there? Are there trial drugs there? And that's what you should be. Because the reality is that the trials need enough patients and enough, the 3460 is so rare that, and especially if you have another polymorphism that compounds it, that nobody's going to run a trial on that. There just aren't enough of you. On the other hand, whatever works in 11778, in my heart of hearts, except for the genetic trials, will work on 3460. And so if you had been given Idibinone or either the Epi 743 or the Stealth product, it would be just as likely to work in you. But the other two agents aren't available. So it's all about adibenone. Genetics are different. The genetics target that exact mutation. So the French group that you're going to hear just in a little while has come up with a way of recreating the correct unmutated version of 11778. That can't help with 3460. Bottom line is adibenone right now would be the most reasonable thing to do.
So I heard him say two numbers, so you can have two mutations at once?
So there's these big three mutations, 3460, 11778, and 14484, that account for probably 90 or 95% of all disease. Then there's a dozen other mutations, some of which by themselves could not do anything. But if you have them in addition to one of the other big three that we just talked about, the combination makes it more likely. And there's probably even a few mutations that by themselves will do it. They're just extremely rare, so we're not talking about them. So it's complicated. But I would say that there's just a spectrum between just variations, and we call those polymorphisms, variations which are a little bit bad, pathogenic polymorphisms, and variations that are so bad they can produce disease alone mutations. But they're all the little things that make us all different from each other.
So before we get to the next question, I just wanted to say one thing. Canada is a multicultural country, and we have people coming from all over the place. And in part of recognition from that, LH1 Canada is a bilingual organization. So if there are people in the audience who would like to ask a question in French, we have people who are willing to assist in translation as well.
Hi, my name is André Barry. I've lived with LHON for about, I would say, 25 years. I'd like to know, just beyond the optic nerve degeneration, did you see any, over time, immune system related issues? I ask because I have extreme fatigue, allergies, I had shingles, vitiligo at 40. Those are the sorts of things. I'm wondering if the genetic disorder affects other parts of my body and how I can control that.
Yeah, I'll take this since I'm older than these guys and therefore seeing more patients. And the answer is, to our knowledge, no. It does not affect the immune system. And having seen many hundreds of patients with labors, I haven't seen that repeated story. That said, anything's possible. And just as I say, well, I've never heard of this medication aggravating the disease. Well, if it does so only 1 out of 100 times, how would I know? And so I don't want to exclude the possibility, but I've not heard that story.
I'd just like to add, when you're dealing with a disease that has 1 in 50,000 people, and then you try to combine it with a disease that affects 1 in 5,000 people, you're going to get some overlap. And it's really hard for us to be able to necessarily recognize whether that overlap is happening all the time because of that 1 in 50,000 disease, or is it just because the population, 1 in 5,000 of those people, happen to have the other disease as well?
Good. My son's taken Relentless Improvement, and they've adibenone for Relentless Improvement, and they recently reformulated to remove the magnesium stearate excipient and replaced it instead by rice concentrate. Is that, what's the...
I don't think it matters.
Okay, I have one more question for the Law in Canada. Do you plan on getting into any lobbying?
Do we plan on any lobbying? I think probably eventually. We're honestly, essentially, we've worked hard to get to the symposium and forming a nonprofit, but absolutely we realize that we're going to have to go forward in sharing our voice with LH1 Canada and working with somebody. Yeah. And certainly anybody who wants to support us out in the audience that has skills and things too, feel free. We need help. Yeah, absolutely.
I'd like to add that the people sitting up here, especially Kevin, Lisa, and the other people who introduced themselves earlier, they pulled this together in less than a year. There are 100 people in this room. That is a phenomenal accomplishment.
My question is back to, I think, an earlier question around what do you do for access to clinical trials if you're Canadian? And I know we took it back to the bigger picture, but I'd actually like to bring it back to that specific place. Are we at a place now where we should actually consider a North American view of clinical trials in this area specifically, given everything you've just talked about? And is that possible? Like if you're a family here today and you want in?
So it is possible, and I have sent patients down to the U.S. to participate in some of the studies. I am very fortunate in that I have a very good inn in Los Angeles sitting next to me. So for some of the studies, I know what the selection criteria are and things like that, and so I try to expedite things. It doesn't mean that I'm going to send patients on a 5-hour flight to LA. I do it myself, and I know how painful it is, but there are closer sites. So certainly there are places where we can arrange for you to go, see some very good doctors down there as well. Unfortunately, some of the trials do not cover travel expenses. Some of them won't cover it if it's international. Some of them will cover it. And it really depends on the study as to whether or not you'll be able to get reimbursed. You may also be able to apply for some funding from your provincial government, depending on what the study is, in order to get some of that covered. But as you know, government moves slower than a snail, so be aware that it's going to take a while.
So,
Yeah, I think the point I was trying to make is that you're not going to have separate clinical trials in Canada. So it's an issue of trying to coordinate and integrate with, I like the term you use, North American clinical trials is just the way to go.
yeah. Just on a very practical sense, if if you're seeing a neuro-ophthalmologist, they have access and understand these clinical trials as well, so should be able to connect the patient to the trial as appropriate. But in addition, we're a very, I think, a reasonably accessible group, and I work closely with the medical geneticist and adult metabolic disease clinic in Vancouver, where we can definitely make these things work on a very practical level.
Okay, my question is, it's good to have iDibino. Now, there's a lot of places you can buy it on the internet. It's always scary to know that you're shopping for something so important on the internet. How do we know which one is good, which one's a good batch, which one is not as good as the other one? Which company? I know you're not supposed to name companies, probably.
Oh, I can name companies.
Oh, you can? Well, please do.
I'm not obliged to anybody.
Oh, okay, well, I didn't know, so I just
So
wanted.
we have actually taken the analysis of 3 companies. That's not to say the others aren't fine, but HBC, Relentless, and I think this one's no longer available, Kirkland, have all been analyzed. And the only difference we found between those and the products made in Europe, well, there's 2 huge differences. One is cost. On average, internet cost per month is about $80, unless you get it through the European agency that makes it per prescription, in which case it's somewhere in the range of, I think it's $6,000 a month. There you go. So one's like 15 times more than the other. So if you were European and you could get a prescription and your insurance covered it, I guess that'd be better. But if you were European and you had to do that out of pocket, you'd be a lot worse off. So the internet stuff is equally valid in terms of what's in it. In terms of dosing, we found a little bit of a difference. The doses tend to be higher on the internet by about 10%. So I think what happens is that Centera, who makes it for $5,000, $6,000 a month, has a very, very better quality control dosing. So if they sell you 900 milligrams, you get 900 milligrams plus or minus 5 milligrams. Whereas if you get it from Relentless, you get 900 milligrams, probably it's going to be 930 and 940 milligrams, because they err on the side of giving you too much more than they do the other way around. Since we don't know the right dose, I don't see a difference. Just to get to that point, please take it equally divided. There are a few patients who say, I'll just take it all at once, it's more convenient. It doesn't work that way. Antibiotics, it's about how high a level you can get. This is trying to prevent apoptosis by ROS. You could have all you want in the morning. If you got 0 at night, that's when the cells will die. That's no good. So spread it out. 3 is the minimum. I have some of my patients who push it to 4 times a day, which is even better. Secondly, take it with food. And thirdly, take it with food that has at least a little bit of oil in it. So you can have it with a salad if you have a salad dressing, and a diet salad dressing won't do. So that little bit of oil helps it get absorbed.
Is there too much iDibino now?
There's too much of anything. You tell me the word, any chemical in the world, you can take too much. So I would not allow you to think, as some people do, which is if a little bit is good, a lot is better. When we did our initial trial in Italy, we used 450 and got exactly the same results as the group in England did with 900. So probably the optimal dose is even closer to 450 than 900. But because it's a pretty non-toxic agent, I have no problem with the 900 either. But I would not go over 900.
Having said that, though, I do, and I know you do as well, Alfredo, check the liver enzymes for our patients on a routine basis, just to make sure that there's no signs of any elevation or toxicity. And that's not necessarily only associated with the idibanone, but it can be related to having taken other medications or ingested other things that interact and cause the liver enzymes to go up.
And please know that too much can be too much. Anything, including idibanone, taken in large quantities carries risk. Even at 900, it probably carries some risk, which can be justified by the benefit. But it's not taking vitamin C. It has real potential for harm.
And along those lines as well, a carrier, really, we don't know why, we don't know what that benefit is at that point. And so one of the concerns with carriers taking the medication is that, are we going to push them to become dependent on the medication and all of a sudden they stop and then become affected? Because now we've tipped the balance where the body cannot cope without having the idibanone in place.
See, that's my other concern with me being on that.
Yeah, we can barely hear you.
Okay, another question. Two questions, actually. Number one, for clinical trials, any for under the age of 18?
So they go down to the age of 15 currently.
Oh, good. And second question, and again, this is much more scientific research. I'm just thinking about mitochondria and Claire. Any animal models yet for replicated for Elhan?
Definitely so. Animal models is the question, and animal models that are good animal models are a huge advantage in doing good research. And the particular model that I think is very, very good has been developed at Children's Hospital in Philadelphia. We're involved in doing research with this group headed up by Doug Wallace, but it happens to be ND6, which is the 1444. So we have a huge colony of mice who have 1444, and they do go blind. Interestingly enough, they go blind at age 2. Whereas humans go blind at age 20. The trouble is, of course, that you'd like it to be sooner because that means every time you start an experiment, you got to wait 2 years before anything happens. So we're trying to tweak it to make them go blind at 8 weeks, which would be a lot more convenient.
And for those of you who are local, Doug Wallace will actually be in Ottawa at the beginning of November to give a keynote address at the university. So if you're interested, we'll let you know.
A couple of little medical questions, please. I'm have been affected for 21 years and did all the bad things, like used to smoke and drink, but don't now. And I'm wondering, I have read, thank you, I have read that I can't take almost any painkiller. I mean, once in a blue moon, I have such a bad headache or something, and I look and the internet says I can't take aspirin, I can't take Tylenol, I can't take acetaminophen. Is there any simple over-the-counter painkiller that I can take?
There's a lot of stuff on the internet that's true. So I obviously don't have the Bible of what's certain and what's not. I just do the best I can at looking at the strength of the evidence, and doing so, I would have rejected what you just said, that these painkillers are dangerous for you, for the issue of labors. So I'll make some mistakes saying this, but I think it's much, much more likely than not that you can take Tylenol or Advil at reasonable doses.
Thank you. The other question is, my son, who is just a carrier, told me this, that his doctor, Mark Tarnopolsky in Hamilton, got him on a vitamin cocktail that includes small doses of creatine daily for the rest of his life. And he got me taking it too. Do you think creatine is worthwhile? Half a teaspoon a day, I believe I take.
We start by saying we don't know because there's been no clinical trial with creatine. But in my heart of hearts, no, I don't think so.
Thank you. Oh, one last question. I believe that we would get more funding publicly and privately and otherwise and more clinical trials if we had more numbers. And I personally believe that there are many more people in Canada who are undiagnosed or diagnosed but sitting in the background and don't want to talk about it or react. Is there anything that we can do? I mean, I think doctors could do more. I think every GP, my GP doesn't know what LHON is, but he has it written in my chart. I think doctors are aware of it. Is there any way that we can help to bring our peers out of the closet, so to speak?
Yes. This story with Brazil didn't start with doctors. It started with a patient. This is the patient who was pretty uneducated, lived in a family where almost nobody could read or write. She was pretty smart, though, and she could read and write. And she noticed that there were a lot of relatives going blind. And when her 14-year-old went blind, she pretty much knew it had to be what made her brothers go blind. So she made a committed effort to go to the big city, the famous city that you've never heard of called Victoria. And there she found internet cafes and spent weeks teaching herself the internet. And there researched it and concluded that her family had LHON. And then in that same internet search found me and sent me a translation from Portuguese to English and said, "Come quickly, my son is blind in one eye, and I figure if it's going to work before the second eye gets involved." Obviously, we could not help the child's second eye. But she educated all of Brazil. Patients can do the educating.
Hi, I have a question. Is there something that can be done to increase the energy of someone that has LHON? I find that my husband who has it is exhausted all the time because it takes so much energy to see. So is it food? Is it stress reduction? Is there something, I don't know.
I don't think it's mitochondria. So, of course, you make a point. You know, every day in the last 3 days, I've been on stage talking, and I'm filled with energy, and I'm feeling excited until I meet my wife in the evening, and then I collapse. So if you concentrate hard at doing something or compensate for it, it's exhausting. I think it's more likely that than mitochondria, and therefore I don't think there's going to be a magic food or supplement. I think that, you know, knowing yourself will be a better approach.
You may hear us say occasionally that we have no good evidence to support blank. And it is a cop-out on our part, but it's partly to get across the point we don't know. And we need to learn more by interacting with you and you interacting with us and asking us these questions. And that's how we learn, and that's how we move ahead.
I think we're going to do one last question.
Is it okay to be a blood donor if you're a carrier, or shouldn't you give blood?
I can't think of any reason not to.
Yeah.
I mean, you're actually turns out
It's not in your red blood
that
cells.
in the first place, if you are a carrier, there's nothing toxic or dangerous. But in the second place, the only cell in your body that doesn't have mitochondria are your red blood cells, which is what you're donating. So everybody is donating. Well, you do have mitochondria and white blood cells, but the white blood cells don't survive the transfusion. So I see absolutely no reason that you couldn't be a blood donor. But you might get them upset if you said you had a disease.
We were talking about food earlier. Is there any food you recommend to eat to help make my sight not go as bad so quickly?
No, I typically encourage patients to just simply have a balanced diet. Again, no clear evidence for food and like nutraceuticals or anything like that in this condition, but balanced diet. And I don't know about you two, but lately I've been talking a little bit more about vitamins that can, you know, like B12, thiamine, and folate, only because those ones, if they're low, they affect the optic nerves. But I don't think the
I agree entirely with you, Claire. I don't think that if you have a reasonable diet, it matters. If you're vitamin deficient, it does matter.
Yeah.
Get those vitamins, and those are the ones that probably matter the most. But we did exactly what you're thinking, an extensive study having hundreds of patients in Brazil, and we went down everything they ate, and we analyzed it for nutritional levels. We went so far as to ask the differences between those who ate mangoes that were ripe and those who were not ripe. And at the end of all this, we got nothing.
I would like to add, though, just because you have labors doesn't prevent you from having heart disease. It doesn't prevent you from having bowel problems. It doesn't prevent you from having other medical problems. So the things we know that work for those are things we still recommend.
Be healthy. And before I forget, there's one other issue. For those of you who are taking idibinone, I don't think that vitamin C is a good treatment for labors. I mean, there's nothing wrong with it, but it's not going to help by itself. But for those on Adibenone, I think taking vitamin C is an excellent idea. Not because of what the vitamin C is doing to you, but what the vitamin C is doing to the Adibenone. The reason Adibenone works is it picks up that electron. When it does so, we talk about it going from the reduced state to the oxidized state. That means it can't do it for a second round. It's done. The vitamin C takes the electron from the Adibenone and puts it back into the reduced state, which means you get to recycle the Adibenone in your own body. So in a sense, you're, without any significant added expense, getting more bang for the buck in terms of the Adibenone. So I advise everybody on Adibenone to take either 250 or 500 milligrams of vitamin C once a day to get the most out of your Adibenone.